afternoon, and welcome to today's PHO Rounds presentation on COVID-19 vaccination in Canada, a health economics lens. My name is Kevin Brown. I'm a scientist at Public Health Ontario, and I have the pleasure of moderating today's session. We'll begin with some housekeeping items to make sure that this session's engaging and optimal. The chat in the Zoom window has been disabled, as well as some of the audio and video features. So at any point during Dr. Chut's presentation, please feel free to submit any content-related questions in the Q&A, and they'll just be addressed at the end during the 15-minute discussion period. And if there's any technical issues, you can email capacitybuilding@oahpp.ca. So I'll now introduce our speaker for today's event, Dr. Ashley Chut. Ashley Chut's a manager of health economics and modeling at the National Advisory Committee on Immunization, Secretariat at the Public Health Agency of Canada. And she is an assistant professor at the Dalla Lana School of Public Health at the University of Toronto. She's an infectious disease epidemiologist and a mathematical modeler with an interest in the use of quantitative methods to improve decision-making related to communicable disease control measures and policies. She's particularly interested in the use of modeling to synthesize and communicate complex information and uncertainty. So I'll now pass it on to Dr. Chut to give her presentation.
Hi, good afternoon, and thanks so much, Kevin, for the introduction. It's a pleasure to be here today to talk to you about the use of health economic modeling to think about the cost effectiveness of COVID-19 vaccination strategies in Canada. Before I get into the content, I did want to just share this disclaimer that this presentation was created by me, and PHO is not the owner of the content and assumes no liability resulting from any such application or use. In terms of disclosures, I have no conflicts of interest to disclose. And so in today's session, I'm hoping that when you leave, you'll feel comfortable explaining the basic concepts of cost utility analysis and their application in evaluating vaccination programs, and also be able to interpret key findings from an economic evaluation of COVID-19 vaccination strategies and consider their implications for designing cost-effective programs. You will hopefully be able to assess how changes in model inputs and assumptions can affect the cost effectiveness of vaccination strategies. And finally, I hope you'll recognize the role of applied health economic modeling for supporting public health decision making. And before I start the sort of main part of my presentation, I wanted to acknowledge all of the following people and groups on this slide who contributed to the work that I'm going to be talking about today. So COVID-19 vaccine recommendations are complex. I think, since the beginning of the pandemic, we've had discussions about who to vaccinate and when. And the conversation has shifted as we've emerged from the public health emergency stage into a period of time where we have endemic transmission. And we were starting to think about a more routine COVID-19 vaccination program. Over time, COVID epidemiology has shifted, and this has really been driven by increases in population immunity from both previous infection as well as vaccination. So we're no longer dealing with an entirely susceptible population. And that has implications for who is most likely to benefit from vaccination. Prior to 2025, all Canadian provinces and territories were accessing COVID-19 vaccines that were procured under federal pandemic investments. So they weren't assuming the costs of purchasing the vaccines. And that's changed in 2025 where provinces and territories are now transitioning to the usual procurement pathways, which means that they need to incorporate budget to purchase COVID-19 vaccines. And they have to make those decisions about who to vaccinate and when, sort of in the context of a limited public health budget and sort of including the COVID-19 vaccines amongst other vaccine programs that are already in place. And so, given the shifting epidemiology, who was recommended to receive a vaccine 3 years ago may look quite different from who might benefit most from receiving a vaccine today. And given the shifting costs to the provinces and territories, there's been an increased focus on ensuring that the COVID-19 vaccination programs provide a good use of limited resources. The reality is that we live in a world where we don't have unlimited budgets, and so we have to make difficult choices. And so, understanding the health and economic trade-offs of different COVID vaccination strategies can be useful for understanding how to use those limited resources in the most efficient or effective way. And so, the work that I'm going to talk to you about today was done to support a recent National Advisory Committee on Immunization recommendation for the use of COVID-19 vaccines in Canada. And this was a statement that was released in fall of 2024. Um, and the idea really behind this analysis was to sort of take a step back and look at the cost effectiveness of COVID vaccination in order to help the committee and the COVID-19 working group think about sort of how to best deploy COVID-19 vaccinations in the Canadian population. And we'll talk about this more in the discussion, also recognizing that cost effectiveness is just one piece of the puzzle that goes into developing those recommendations, but was a way to sort of, again, sort of reevaluate the current epidemiological landscape. So I'm going to be talking to you today about economics, and so I wanted to spend a little bit of time just talking about some of the terminology that you'll hear me use, and you may have heard in other talks about health economics. The work that we did and the work that the sort of economic evaluation that is recommended for vaccination programs in Canada is what's called a cost utility analysis. You'll hear me use that term interchangeably with cost effectiveness analysis. A cost effectiveness analysis is a broader umbrella term. A cost utility analysis is a form of economic evaluation that assesses the value for money of an intervention by considering both the costs and the health outcomes. And the outcomes are measured in what's called a quality adjusted life year, or a QALY. And the use of this generic measure of health is what makes a cost utility analysis a cost utility analysis. So we're using this particular measure, the QALY, which combines how long a person lives as well as how well they live while they're alive. So it's not just survival, but it's survival and sort of your state of health while you're alive. And so one QALY is equivalent to 1 year of life lived in perfect health. And the value of the QALY is that it provides a common unit that allows us to compare the value of health interventions that may otherwise be very difficult to compare. So as an example, just say you have an intervention that results in fewer respiratory hospitalizations and deaths in your population, and you have another intervention that improves mental health. If you only had enough money to implement one of these interventions in your population, it would be very difficult to compare improvements in mental health to prevention of hospitalizations and deaths. And so a QALY, which uses not just time lived, but also your health during, or sort of the sort of level of your health while you're alive, allows you to make those comparisons across these what seem to be very different interventions. When we do a cost utility analysis, we generate what's called an incremental cost effectiveness ratio, or an ICER, which is a summary measure of the additional cost per unit of health gained when you're comparing a new intervention to an existing alternative. And the ICER provides insights into the efficiency of different interventions. And this can help inform policy decisions. And I'll talk a little bit about how it can inform policy decisions now. I'm going to just walk you through an example of how we calculate the ICER and how we interpret the ICER. So what's shown on this slide here, in the center, we have our comparator, which is our current standard of care. So for the purposes of today, let's just say our comparator is do nothing in our population. And then we have a new intervention that emerges that we're thinking about introducing for our population. So what we can do is we can map this new intervention in terms of its effects in both improvement in health, as well as the costs associated with that intervention relative to our comparator. So our new intervention, which is shown in blue here, is more effective than our comparator. So what that means is that it improves health in our population, but it also has higher costs than our comparator. So we're getting more health in our population, but we're also paying more for that health. And the question is, how much should we as a society pay for that improvement in health? Depending on where an intervention falls within this plane, we can help us make decisions. So what I've shown over in this red box here is an intervention that falls within this quadrant, costs more than your comparator, and is less effective. So essentially, you're paying more for an intervention that generates less health in your population. And in this case, you would never want to adopt your intervention. So we would prefer the standard of care, and some sort of health economic jargon that you may hear is that we would say the current standard of care dominates our intervention. Sort of best case scenario is a situation where we have a new intervention that is more effective than our comparator and costs less. So in this case, we are essentially generating more health in our population and we're saving money. So if we have an intervention that does that, we would generally always prefer to adopt the new intervention. And we would say the new intervention dominates our current standard of care. Most typically for health interventions, we have new interventions that cost more but are more effective. So we're paying more, but we're getting more health in our population. And we sometimes have interventions that cost less and are less effective. So the decision whether or not to adopt interventions that fall into either one of these yellow quadrants is trickier. It's not as clear. So you're not, if you're paying more and you're getting less health, that's a pretty clear decision. If you have something where you're paying more and you're getting more health, you have to have some sort of guide to help you decide how much is too much to pay, or how much, sort of what your threshold might be. So what you'll sometimes see people refer to is something called the cost effectiveness threshold, which I've indicated by this yellow dashed line in the graph. And so if you have a cost effectiveness threshold, this is essentially a value that you're willing to pay for quality adjusted life year gained in your population. What I've shown here on the right-hand side of the slide are some cost effectiveness thresholds that are used around the world. I would say the UK is probably the best example of a country where they have a very specific cost effectiveness threshold. So for vaccines in particular, a new vaccine has to have an ICER of £20,000 per quality gained or less for that intervention to be favored. And if it falls above that £20,000 per quality threshold, it would not be recommended to be adopted in the population. The World Health Organization suggests that, or recommends that, countries use a cost effectiveness threshold of 1 to 3 times their per capita GDP. So GDP per per capita in Canada is around $70,000 per. So if we had an intervention that fell below $70,000 per QALY, we might use that as a metric to determine whether or not an intervention is cost effective. Wanted to emphasize that in Canada, we do not have an official cost effectiveness threshold. So although we can look at ICERs and generate, estimates of these sort of summary measures of how much each additional unit of health gained costs, we don't have a hard metric where we would say, like the UK, where we would say if it's above this, we're not going to recommend the intervention be used in the population. Despite not having a clear threshold, we can still use these ICERs to get a sense of sort of relative efficiency of different interventions. And again, if you have something that's costing $1 million per quality adjusted life year gained, that's a sort of a clear measure of an intervention that you would be unlikely to recommend be adopted in your population. So far we've been talking about, we have one intervention, we're comparing it to some current standard of care or some comparator, but oftentimes we'll be comparing more than two interventions. And what we're going to talk about today, we're looking at different vaccination strategies. And so there's more than two. And in a situation where we have three or more interventions, we do what's called a sequential analysis. And in a sequential analysis, each intervention is compared to the next most costly non-dominated intervention. And so what do I mean by non-dominated? What I mean is we eliminate strategies, or we can exclude them from the suite of potential strategies that we would consider using in our population if there are other strategies that result in more QALYs gained at lower costs. And I've included here two different terms, dominated and extended dominated. We don't really need to get into the weeds in terms of the difference between those. But really the take home is that by doing the sequential analysis, we can identify interventions that would never be cost effective when we have other options available to us. Once we do the sequential analysis and we remove all these excluded strategies that would never be cost effective, we identified the most cost-effective strategy as the strategy with the highest ICER that falls below the cost-effectiveness thresholds. And again, a reminder, in Canada, there's no official cost-effectiveness threshold, but you'll frequently see $30,000, $50,000, or $70,000 per QALY used as benchmarks. And today I'll be anchoring to the 50,000 per QALY threshold just to help sort of walk through some of the results. So that's it for background. And now I wanted to talk specifically about the economic evaluation of COVID-19 vaccination strategies. And so again, just a reminder that this was really focused on trying to understand the cost effectiveness of different age or risk-based strategies for the Canadian population. And to do this, we followed a modeled cohort of 1 million people over a 16-month period. So the period of time that was representing July 2024 to September of 2025. We started the model a little bit ahead of when vaccination had been initiated for the fall campaigns over the past couple years, which has typically been in September or October. And the idea was that we have seen in the epi data that there seems to be, again, it's difficult to talk about trends when we only have a few years of data and we see differences from year to year, but sometimes the vaccination programs are starting after we see an initial increase in COVID-19 activity. So by starting our model in July, we were able to explore in some scenario analyses what would happen if we started the vaccination campaigns earlier to better match what we're seeing in terms of the epi. The characteristics of our modeled population were based on the Canadian population, so including the age distribution of the population, as well as the proportion of the population who have one or more chronic medical conditions. And we used the presence of at least one underlying medical condition as a marker for individuals who had higher risk of experiencing severe COVID if they were to be infected. And again, this was used to look at some risk-based vaccination strategies in the population. So as I mentioned, we looked at some different vaccination strategies with the eligibility defined by combinations of age cutoffs as well as chronic medical condition status. Um, we included a strategy that was similar to Canadian recommendations at the time of the analysis, and we selected strategies that were considered feasible to implement. So we didn't explore all possible age cutoffs. We weren't trying to do an optimization experiment to identify, the precise age at which the programs might be most efficient. We were trying to align with the sort of current age cutoffs used for different um, other vaccine preventable disease programs, as well as the existing COVID-19 recommendations. And so using our model, we were able to estimate the number of SARS-CoV infections treated in the outpatient and inpatient settings. And we used this to calculate ICERs in 2023 Canadian dollars per collie. The perspective that we used for our analysis was the health system perspective. And so what this means is that we're including health outcomes and health system costs occurring within the publicly funded health system. We did also conduct an analysis from the societal perspective, which includes the costs borne outside of the publicly funded health system, so things like out-of-pocket expenses, as well as lost productivity because of time off of work due to illness. But I'm going to focus today on the health system perspective. So our model was actually a hybrid model. And so I'm going to just quickly describe the approach that we used. What's shown in the top box in blue is the initial model that we used to estimate the burden of COVID-19 that would occur if we were to stop vaccinating the population. So essentially what this represents is this is a dynamic compartmental model. So it has feedbacks within the model that allows us to account for things like herd effects, and also accounts for population immunity due to prior infection and vaccination, including, waning and boosting of that protection. And so what we did is we ran this transmission model with vaccination, with infection occurring in the population up until July of 2024. And then we stopped vaccinating and we projected what would happen over the subsequent 15 months without any additional vaccination in the population. So those gave us estimates of expected burden without additional vaccination. And then we used those outputs to feed into our second model, which is shown in orange at the bottom. So this is a static model, which means we don't have those dynamic feedbacks. But essentially what we're using this static model for is to look at the trajectory for people who do have infection in terms of whether or not they require whether their infection results in medically attended COVID-19. So what we mean by medically attended is, do people who are infected require medical care either by visiting a healthcare provider, going to the emergency department, or requiring hospitalization, potentially requiring admission to ICU. Following any of those outcomes, individuals can then recover. They can experience post-COVID condition or PCC, or they can die from their infection. So the reason we used this hybrid approach was that by doing a static model for the second piece in terms of the trajectory of infected people, was that we could do more nuanced modeling of vaccine effectiveness. And also we were able to explore different assumptions about the timing of vaccination receipt relative to peaks of COVID-19 activity. I just wanted to briefly mention some of the assumptions that we made, particularly related to vaccine effectiveness. So we assumed that vaccines provided protection over a 6-month period. And we assumed that vaccine protection waned more rapidly for those who had less severe disease. So for people whose infection resulted in an outpatient visit, vaccine protection waned more rapidly over that 6-month period than for those who required hospitalization following their infection. We also assumed in our primary analysis lower vaccine effectiveness for people who were at higher risk, so those with underlying medical conditions. Um, for those age 65 and older, we also explored a booster dose, so a second dose given within that 1-year period. In our main analysis, we assumed it was 6 months after that initial dose. And again, this was based on NACI recommendations at the time we did our analysis. And for those individuals, we assumed that if they received a second dose, that their VE would return to that original levels and follow a similar waning pattern. Our vaccine coverage data was based on data from the spring 2023 and fall winter 2023-2024 campaigns. And we saw that uptake increased with age. So it was 6% for those less than 5 years of age to around 53% for those 65 years of age and older. And we saw that there was 11% uptake for a second dose at that, in our model, 6-month interval for those age 65 years and older. And I've also just included in this table the proportion of the population that would have fallen into the higher risk category in our model by age. So the vaccination strategies and scenarios are shown here. What you'll see is that we started with, at the top of our pyramid, with a very restricted program. So we assumed only individuals age 65 and older would receive the vaccine, regardless of their risk status. And then we looked at increasingly expansive programs. So inclusion of all adults 65 and older, plus higher risk individuals age 50 to 64. And then going the inclusion criteria, or expanding the inclusion criteria to offer the vaccine to everyone 65 and older and everyone higher risk, age less than 65. And then finally, we looked at a comparison of everyone 50 and older and higher risk individuals 50 or sort of less than 50 years of age offered the vaccine. And for all of these strategies, we looked at the strategies with and without a second dose offered for those age 65 and older. We also looked at a number of alternative assumptions. So one of the most sort of uncertain pieces of data that we had for our model was vaccine price. So we didn't have a Canadian vaccine price at the time that we did our analysis. And so we used data from the US CDC. So they have public vaccine list prices for the mRNA vaccines. And we used those public prices along with historical data that we have within Public Health Agency of Canada, looking at the relative price differentials between those public prices and the confidential Canadian negotiated prices received through the bulk procurement program. And so based on that, we did our initial analysis using an assumed vaccine price of $43 per dose, but we looked at higher values as well, given uncertainty around the vaccine price. We also looked at differences in vaccine wastage. We looked at what would happen if we had higher COVID-19 incidence in the population than we assumed in our base case. We looked at different shapes of the epi curve. So what happened if we have a sort of flatter wave, or what if we have a wave that is sort of more peaked in the wintertime? And finally, we looked at program timing. So what happens if we're better able to match our timing of vaccination to the peaks in COVID-19 activity? So moving on to results, we started off by looking at the impact of vaccination for preventing outcomes. Specifically, what's shown on these graphs are the cases averted relative to no vaccination for preventing outpatient cases, inpatient cases, PCC cases, and deaths. What's shown on the y-axis are, as you go down the y-axis, we're having more expansive programs. So we're including more of the population in the program. And the darker blue lines or bars represent an annual dose for everyone in the population, and the lighter blue bars represent the results when we include a second dose for those age 65 years of age and older. And generally what we see is that although the overall proportion of COVID-19 outcomes averted in the population is relatively low, It's not insignificant, particularly given the low assumed vaccine coverage. And in particular, we see relatively large effects for the prevention of COVID-19 hospitalizations and deaths. We also found that the addition of the 6-month dose for those 65 years and older didn't have a very large impact on outcomes averted. And again, this relates to the fact that we're assuming that the uptake of that second dose is relatively low. And what's shown in orange here is the strategy that is most similar to the NACI recommendations at the time we did our analysis. So we also looked at a metric which is called the number needed to vaccinate. So this is the number of people that you need to vaccinate to avert one outpatient case, one inpatient case, one post-COVID condition case, or one death. I just wanted to draw your attention to the fact that the x-axes on these graphs are different for each of the outcomes. So the NNV for preventing a death is much higher than the number of people you need to vaccinate to prevent an outpatient case. But for the more severe cases, so the inpatient cases and deaths, we found that the number needed to vaccinate increases as the age cutoff for vaccination is lowered. So in other words, as we have these more expansive programs that include the younger ages, the vaccination programs are less efficient than when we have these more restricted programs. We also found that the number needed to vaccinate increases when we include that 6-month dose for the 65 and older population. And finally, we didn't see a strong age trend for outpatient and PCC cases, in contrast to what we see for the hospitalized cases and deaths. And again, this reflects what we see in terms of the epi, where those who are older are more likely to experience severe outcomes. And again, just highlighting where the NACI recommendations at the time of our analysis fall relative to the other strategies. So looking at the current program cost effectiveness, we calculated the ICER, and what we found was that compared to no vaccination, the ICER was around $21,000 per quality adjusted life year gained. And so we talked a little bit about thresholds and commonly used ones. This one is at $21,000 per quality, would be considered a cost-effective threshold, a cost-effective program using a $50,000 per quality threshold, as well as even using a $30,000 per quality threshold. So this would most likely be considered a cost-effective intervention in the Canadian context. The one thing I wanted to highlight is this is looking at the cost effectiveness of the overall program as recommended. And I'll talk to you in a moment about unpacking that to get a sense of, of the different groups that are included in the program, what is the cost effectiveness in those particular groups. But before I go there, I did want to just briefly talk about how we addressed uncertainty in this analysis. So, we're trying to estimate the cost effectiveness of COVID-19 vaccination program. There's a lot of uncertainty related to the epidemiology, the seasonality, the timing of these programs. And also there's uncertainty about the vaccine price, there's uncertainty about the vaccine effectiveness, and there's uncertainty about wastage. So we saw that sort of towards the later stages of the pandemic, there was a lot of vaccine wastage that was occurring. And so we tested all of these assumptions in scenario analyses. So we varied these different assumptions one at a time. And what's shown in this table are the ICERs for these different scenarios. And you'll notice there's a lot of green in the table. And what that means is that the ICERs were less than $50,000 per quality compared to no vaccination for all of these assumptions. The two exceptions where the ICER was above $50,000 per quality was when the vaccine price was higher than the $43 per dose that we assumed in our base case. And so I'll get back to vaccine price in a moment, but just wanted to flag that, despite all of the uncertainties that we have, it was really vaccine price that the model was most sensitive to. So what we just talked about was comparing the current program to no vaccination, and that's what's shown by this orange dot, and it's labeled here current program. And so that had an ICER of around $21,000 per QALY. But when we started adding in sort of piece by piece, adding in the different age and risk groups, we're able to sort of essentially walk up what's called a frontier here and estimate the ICERs sequentially for addition of each of these different population groups in order to get estimates of the efficiency of vaccination for these different groups. So what we see is when we sort of move along the y-axis from the least costly intervention, which is no vaccination, up to the vaccinate 65 plus annually, we have an ICER of around $8,000 per QALY, which would be considered highly cost effective. The next most costly intervention is the addition of annual vaccination for those aged 50 to 64 years at high risk. And this has an ICER of around $69,000 per QALY. So adding in that group, we would be paying around $70,000 per QALY. So we can keep doing that analysis and sort of walk up this frontier. We've already talked about these first two initial groups. What we find is that adding in a 6-month booster for those 65 and older results in an ICER of around $138,000 per QALY. And then adding in an annual dose for those less than 65 years at high risk has an ICER of $280,000 per QALY. So although the program overall is quite cost effective, we see that really the sort of most efficient part of that program, or most of the benefits, are deriving to those 65 years and older, and then the 50 to 64-year-olds at high risk. So again, we did our scenario analyses where we looked at a bunch of different different scenarios and varied our assumptions. And what we found here was that, consistent with the base case, ICERs were always lowest for annual vaccination for the 65-year and older population. And compared to no vaccination, ICERs were always less than $50,000 per QALY, even when we assume much higher prices for the vaccine or increased vaccine wastage. The next most efficient strategies were generally to expand the program to include higher risk people aged 50 to 64 in the annual program, with ICERs exceeding $50,000 per QALY for most of the scenarios except for except for one, which was the assumption of equal vaccine effectiveness for average and higher risk individuals. We also found that for two scenarios, addition of a 6-month dose for those age 65 and older would be the next most cost-effective intervention if there was a flatter curve, so a less pronounced winter wave, or if the vaccination program timing could be optimized to match peak disease activity. And the ICERs were less than $50,000 per QALY for both of these scenarios. So in terms of the alternate assumptions, I'm just showing here that for everything else, the ICERs always exceeded the commonly used cost effectiveness thresholds. Just briefly wanted to mention that we did an analysis looking at how vaccine price affects program cost effectiveness. And using a $50,000 per QALY threshold, we found that our results were pretty robust. So if the vaccine was priced anywhere from $35 to $110 per dose, vaccinating all adults age 65 and older was always identified as the optimal strategy. And we found that the vaccine needed to be priced at between $15 and $30 per dose for inclusion of high-risk adults age 50 to 64 to fall below that $50,000 per QALY threshold. And finally, we found that inclusion of a 6-month booster for 65 and older would only be cost effective if the vaccine price was between $5 and $10 per dose. So moving on to the summary of this analysis, when thinking about how to design a cost-effective COVID-19 vaccination program, I think there are really 3 key things to think about, which are the population risk, timing, and price. So we found that COVID-19 vaccination programs are most cost effective when focused on people at higher risk of severe outcomes following infection. And although we found the recommended program was cost effective overall, when we compared it to no vaccination, we found that that the components of the program focused on lower risk subgroups were less efficient when we looked at those subgroups in isolation. And we consistently found annual vaccination for adults age 65 and older to be a cost-effective strategy. And those findings align with economic evaluations conducted in the US and the UK that also support annual vaccination for older adults. As discussed, we found the results were quite sensitive to vaccine price. And we also found that the timing of vaccine program delivery could impact the estimated cost effectiveness. So if we're able to shift the timing of vaccination programs to better match periods of high COVID-19 case occurrence, that could enhance the program efficiency. And the lack of established vaccine prices does make it challenging to use economic evaluations to inform program decisions. We found that our sort of main finding was pretty robust, regardless of the changes that we made in vaccine price. But we also acknowledge that when a province or territory is trying to design a vaccination program, the budget impacts can be quite variable depending on the vaccine price that is assumed to when you're designing that program. So I told you that this modeling was done to support the NACI statement. So I wanted to just close the loop in terms of what that recommendation was. So before I sort of go through the recommendation, I also wanted to emphasize that NACI considers a number of factors when they develop their recommendations. Economics is just one piece of it. And so the NACI recommendation ended up recommending um, an annual vaccine, strongly recommending an annual vaccine for all adults 65 and older and individuals with underlying medical conditions less than 65 years of age. And also strongly recommended a second dose per year for adults aged 80 and older. And I think within the statement, there was the economic evidence was used to discuss some of the considerations for provinces and territories in terms of groups that they may or may not want to include or consider including depending on budget availability. In terms of limitations and considerations, you'll note that the NACI recommendations, those population groups don't correspond exactly with the groups that we modeled in our economic evaluation, really due to data limitations. So we did not include immunocompromised populations specifically, and we did not include other groups recommended for vaccination, such as individuals from First Nations, Métis and Inuit communities, members of racialized and other equity-deserving communities, pregnant people, essential service workers, and so on. We excluded the potential impact of vaccination for reducing transmission or reducing infection risk in unvaccinated populations. And we note that the exclusion of these indirect effects will underestimate cost effectiveness, but also acknowledge that the coverage of the vaccine was relatively low, such that we wouldn't expect to see dramatic indirect effects in our modeled population. And the health effects due to post-COVID condition were only modeled for up to 1 year. So we would be underestimating the health and economic impacts for those experiencing a longer duration of illness. So my last slide, I wanted to just make the case for using modeling and economic evaluations for public health decision-making beyond COVID. I hope that you will sort of agree with me that model-based economic evaluations can help us make informed choices when resources are limited. They allow us to compare value for money across competing interventions and allow us to anticipate the impact of policies before implementation. I think we saw for the COVID-19 analysis, and it's not unique to that, but they can also allow us to distinguish between important and unimportant certainty and can support transparency in decision making. And wanted to close just with this quote, which is the appropriate way to judge economic evidence is not whether they embody some ultimate truth, but whether they lead to a better decision than would have been made in their absence. And I think that's really the take home for me for using these sorts of analyses to support decision making is not that it's going to tell us what decision to make, but to help us make more informed decisions. Again, wanted to acknowledge everyone else who contributed to this work and thank you for your attention and very happy to answer questions.
Thank you for Dr. Chute for your thoughtful, informative presentation. Um, we'll we'll be opening the floor for a Q&A session. There's already a number of questions in the chat pod, so we'll uh, get started with those. If you haven't already, though, just go ahead and submit your questions into the chat pod, and we'll get to as many as we can. So the first question is, um, can we can an ICER be used for any for any public health interventions like universal masking, um, school closures, lockdowns, um, like we did early on in the like we had early on in the COVID-19 pandemic? The first question is a hard question.
It's the answer is yes, absolutely. I think, the challenge for anything is that you need to be able to measure it. So I think, if you have an intervention and you have a measure of effect and you are able to essentially model that out in terms of what that means in terms of differences in health in the presence or absence of the intervention, then absolutely you can do it. I will say that for today's presentation, we focused on the health system perspective, which is a little bit of a narrow focus. So we're really looking at, healthcare, health system, public health system impact. One of the things that was really relevant during the pandemic were these broader societal impacts. And those can be quite challenging to measure. And, that applies to any intervention that we would use during COVID, vaccination as well, but also things like masking or improvements in air quality. The sort of measurement of a sort of quantification of those sort of broader impacts can be challenging. But I would say, like, short answer is absolutely yes.
Air quality is an interesting example. Uh, Universal masking as well. They're all, it kind of makes my head hurt a little bit trying to figure out how one would quantify costs in some of those circumstances, though. Um, so the the second question that we have here is, uh, the, does a cost utility analysis for vaccines occur once, or can it occur kind of repeatedly over time? Um,
Can occur repeatedly over time. And it's a really interesting question because I think this is probably very pertinent to a question like measles. So, when we first had a measles vaccine and we had a lot of measles disease, the, economic evaluation would probably look quite different from an evaluation that you would do now, where you have, a highly vaccinated population. And so again, this is maybe not the best time to talk about measles as an example, but that the sort of calculations change a little bit because if you reduce vaccination by a small percentage for a vaccine where we've have established programs, the incremental benefit of vaccination may look quite different from a situation where you have you're introducing a vaccine for a new vaccine preventable disease. Having said that, I think COVID-19 is a really good example where, if you were to do an economic evaluation at the start of the pandemic versus now, you know, you would get very different looking ICERs because early on we had a highly susceptible population, so the epidemiology changed. And so, yeah, I think absolutely they can be done and they should be done. I think the challenge becomes, again, how do you capture all of the benefits associated with vaccination? Because they may become less obvious in a world where you have a well-controlled disease versus a world where you have a lot of circulating disease or sort of circulating infection.
Yeah, so it works well. It works well in the circumstances that we have for COVID-19. For measles, it'll be much more difficult to do because it's currently relatively well controlled. The counterfactual, I guess, or the scenario with it out vaccine is a very distant memory. Another, we have just lots of great questions here. Um, I really like this. This is a really interesting question, I find. Given that there are now a number of vaccines for seasonal pathogens, so we're talking about influenza, RSV, and COVID-19, would there be a benefit in assessing the cost effectiveness of vaccine strategies for all three pathogens in combination? Would the most cost-effective strategy for each individual vaccine always result in the optimal use of available vaccines to reduce burden from all three pathogens?
It's a really good question. And so I think that it's something that comes up a lot is, one of the things that is nice about using the ICER and using quality adjusted life years to measure across different pathogens is that in theory, you should be able to compare, if you conducted a cost effectiveness analysis of COVID and you did one for RSV and you did one for influenza, you wouldn't necessarily have to do them all together. In theory, they should all be, you could get ICERs from each of them and compare them. But if the question is, how do we use all of those vaccines in combination to come up with sort of the optimal sort of, you know, optimal program design, then yes, I think you could do that, and you would need to model them all together and think about things like, co-administration or sort of differences in timing of like when you would ideally administer the vaccine relative to when, you start seeing increases in transmission. So I think that sort of more holistic view of vaccination for respiratory pathogens is a really interesting question. And I think it's really salient right now as we have, COVID vaccines and RSV vaccines sort of newly becoming part of our annual programs. Or not, I guess RSV is not annual program, but yeah.
Understood. Okay, so we only have time for one more question. There's a few other questions, but we won't necessarily we won't be able to get to those. So um, our last question uh, is um, is whether this type of analysis can be used by procurement in negotiating vaccine dose prices with manufacturers. I imagine it can provide some leverage to it must cut both ways, but I imagine it might provide some leverage to negotiate a lower price per dose if that meant inclusion of expanded groups beyond the 65 plus.
Yeah, I mean, I can't really speak to the question about procurement. I will say that in the UK, where they have a very specific cost effectiveness threshold that they have, they're able to really establish, what is the price at which we would consider the vaccine cost effective. And that I think can be very helpful for, identifying, do you implement this program or not? I think in Canada, this information is very useful, knowing the price at which a vaccine program is potentially cost effective or not, is useful in terms of the actual procurement process. I mean, that's outside of my job and outside of my scope. But I think in general, that information is useful. because for a province or territory thinking about implementing a program, if the vaccine is, 3 times what it really needs to be for it to be cost effective, then, they would likely want to reevaluate whether that's good value for money or if they could use their resources for something else.
Okay, thanks, Ashley. So um, no, we're now at the conclusion of today's webinar. I see one last, more of a comment, but the comment was, I should repeat it, uh, saying, just saying thanks, that it was really one of the clearest explanations of incremental cost effectiveness ratios that I've ever heard. And I'd like to echo that as well. I thought it was, I thought your background slides were really incredible, incredibly clear. And so I think everybody uh, at today's webinar will really benefit from this super informative, engaging presentation. And thanks to everyone here who was able to join us. Your time and active participation is really appreciated. Um, We'd also like, I'd like to put in a plug for other talks in this PHO Rounds talk, specifically another talk about cost effectiveness modeling that involves mathematical modeling of infectious diseases as well. That is a modeling rounds that will be held on September 23rd. And the session is called Bridging Hepatitis C Care Gaps, a modeling approach for achieving WHO hepatitis C elimination targets in Ontario. And it'll be presented by Beata Sanders and a team. Um, so we hope you can join us for that presentation. So that's September 23rd. You'll also receive a brief anonymous survey following today's session. We encourage you to take a few moments to complete it, as your feedback is invaluable in helping us strengthen and shape future programming. Thanks again, and we wish you a wonderful day. And thank you so much, Ashley, for presenting today.